the fellowship of the All India Ophthalmic in super specialization. So he did his FICO in the cornea from us, aside from doing his cornea from various other places. At a fairly young age, he's been the recipient of various awards, and he's a sought-after speaker. He's got quite a few papers and publications in peer-reviewed journals, and he's the director of Vision Eye Center and a consultant at Sir Gangaram Hospital in New Delhi. Tushar will tell us about the various ablation profiles we get post-refractive surgery, and what is the new things to be learned on, and why, first of all, are things like ablation profiles important to us. Over to you, Tushar.
Thank you, sir, for the introduction, and thank you for having me here in this wonderful webinar. So I'll be talking about the ablation profiles that we have today in refractive surgery and how they are different. So as we know, LASIK and PRK have been around for decades now, but the issue with the original ablation profiles, even though they were able to correct refractive errors adequately, was the induction of aberrations. And Dr. Mukesh also stressed on the importance of aberrations that exist in the eyes and how worsening of aberrations can really hamper the quality of vision. So this is what was happening originally as well. And a lot of these symptoms were intolerable to patients. So the standard ablation profiles, what was happening is that the shape of the cornea was becoming extremely oblate. And that was primarily because of the peripheral rays of the laser beam. So they fall on the cornea tangentially. So these rays were getting reflected, and they also have a longer path length. And along with the interference from the plume that is created, there were undercorrections happening peripherally. So there is less ablation happening peripherally. And that is what was leading to the induction of spherical aberrations after refractive surgery. So it was realized that the solution to this had to be the need to customize approaches. And that is what led to the need for the ablation profiles that we have today, which is Wavefront Optimized surgery, Wavefront Guided, and Topography Guided. So I'll be talking briefly about each of them and how they are different, and in which situations which would be better over the other. Before that, I'll just quickly talk about what the ocular wavefront is. So a line that you draw perpendicular to the rays of light entering or exiting the eyes is the ocular wavefront. So that would be a plane wavefront when you have a parallel beam of rays, and it would be a spherical wavefront when you have a converging beam of rays. And any deviation from the normal here is what constitutes as aberrations, and this leads to imperfections in image formation. And the symptoms that we have that Dr. Mukesh also spoke about, such as glares, halos, starbursts, night driving problems, loss of contrast sensitivity, all of those are the consequences of increased higher order aberrations in the eye. So first I'll talk about Wavefront Optimized approach. So what happens here is basically there are additional laser pulses that are being given in the periphery to counter the inadequate ablation that is happening there. So this leads to the minimization of the spherical aberrations that are being induced. What is important here, though, is that this particular technology is not measuring the pre-existing aberrations and not correcting those aberrations that exist in the eye preoperatively. So this procedure is ideal and works pretty well in somebody who has a normal topography and has otherwise low levels of higher order aberrations, because there is no need to really correct the higher order aberrations in an individual with an otherwise normal eye. Wavefront guided treatment, on the other hand, in addition to treating the refractive error, also measures the wavefront of the eye, measures the higher order aberrations that exist in the eye preoperatively, and treats that as well. So that translates into much better quality of vision in somebody who has pre-existing higher order aberrations above a normal value of root mean square of 0.3. So there are a whole range of aberrometers available. As we know, these are the main technologies such as Hartmann-Shack, Schoening, and ray tracing. The one that is most commonly used and the one that we've also been using is the eye design, which is again a Hartmann-Shack aberrometer. This is a publication that we had in JRS, where we had compared Wavefront guided LASIK with SMILE and myopic eyes, and we found better visual outcomes with Wavefront guided LASIK. And even in other studies, as you can see, the predictability and the efficacy of Wavefront guided LASIK is extremely good. Most patients being within 0.5 diopters of residual spherical equivalent. So this definitely has certain advantages. It leads to less induction of higher order aberrations, uh, a better post-operative wavefront profile. There is better contrast sensitivity, better night visual performance, and consequently, better patient satisfaction. However, every treatment has limitations. The limitations with wavefront guided approach is that you are taking measurements at a particular point in time. So those are static measurements, but the eye is not a static optical system. The aberrations are completely changing with various factors that come into play. An important factor is accommodation. So again, depending on how much the patient is accommodating, your measurements might vary, and you might not really be treating the aberrations that you need to be treating even with wavefront guided approach. The next and the final approach that I'll be talking about is the topography guided treatment. So what is being done here is you have a topographer that could be a placido topographer or a Scheinflug topographer, and that basically gets the topography and that's fed into the system, and then the excimer laser treats that. So the aim here is to regularize the corneal surface and to reshape that cornea into a best fit A sphere. So you're not looking at the aberrations of the optical system, but you're looking at the corneal topography and regularizing that. So this also has been found to have extremely good visual outcomes, extremely good efficacy and predictability as compared to other procedures. The particular advantage that you have with the topo guided approach is to be able that you can use it where wavefront measurements are not possible. So when you have extremely irregular corneas, when you have corneal scars or extremely decentered ablation zones or post-radial, post-RK or post-keratoplasties, this is when this approach is particularly useful because you can't really use any other approach correctly in these kinds of situations. So we had used this in a patient who had been referred to us after an intraoperative flap loss during LASIK, and the patient had a very irregular stroma and very irregular epithelium on top of that as well. So the topo guided treatment that we did was able to regularize the corneal surface to a great extent, and we got much better improvement in visual acuity as well. But what is important here again is that you should be taking good quality scans. You should not be having reflections on the corneal surface, because wherever you're missing those placido discs is areas where the topography is getting extrapolated. So in this particular scan, you have good pupil recognition, you have iris registration. So this is a good scan. However, when you look at this, you see that the iris registration is absent. So this is the kind of scan that should be excluded, and these are not the scans you should be taking for a topography guided treatment. So both these treatments have extremely different approaches. Both lead to extremely good outcomes, but both of them consume more tissue than conventional treatment, and also as compared to wavefront optimized treatment. So just to summarize what I just spoke, when you evaluate a patient preoperatively for LASIK or PRK, you should also look at whether the topography is regular, if there are any visual symptoms with the mesopic pupil, if the visual acuity is not up to the mark. The best corrected visual acuity is not 6.6. If all of these things are normal, then a wavefront optimized approach works pretty well as well, because there is nothing irregular in the optical system or in the cornea that you need to correct additionally. But when you have any of these problems that exist in the optical system, it's best to do a wavefront measurement, look for aberrations. If you're able to get valid and reproducible measurements through an aberrometer, then a wavefront guided approach would be recommended here. If you're not getting valid measurements with an aberrometer, then a topo guided approach would be recommended. But both wavefront guided and topography guided work extremely well in these situations, and either of them, depending on the platform that you use, can be used in these particular situations. Particularly, if you're getting good measurements. So to conclude, advancements in technology have significantly improved the quality of vision that we are now able to achieve in refractive surgery. Wavefront guided ablation is particularly beneficial when you have eyes that have increased pre-existing higher order aberrations. Topography guided ablation is of particular use when you have irregular corneas or where you're not able to get accurate aberrometric readings. Thank you.
Thank you. Tushar, that was indeed enlightening, and in a very concise manner, you told us the differences between what we know most of us are doing in almost 80% of the cases, Wavefront optimized, and the indications for Wavefront guided and topo guided.